I just like that. She's a so she'll be secretary. Yeah, kind of. Yeah. So. Hi, David Dalton. Good to see you again. Hi, Kathleen. Hi. How you doing? Great to see everyone here today. Oh, excellent. Yeah. Oh, this is great. All right, well, let me open the thing. I got it. Thank you. No, there's nothing. Standard.
I feel like I should introduce you. Every year.
You know, I can't do it. I'm breaking my screen.
Oh my gosh.
You know, like it's
So we picked up the option for 2019.
Yeah, you already did that. Yeah.
It's always a step ahead of me.
So I got 1 year. Yeah.
All right, good morning, everyone. I think we will get started this morning as we have a good agenda today of a lot of issues that I wanted to have time to dive into. So I want to get started. We have a new member joining us. I'm going to let David Seltz do the introductions in just a second. But before we do that, I think we should approve the minutes of our last meeting, which were on October 18th. Is there a motion to approve? Anyone? Second? Okay. All those in favor of approving the minutes?
Aye.
And then those in opposition? Okay. So we have a new designee from administration and finance. David, do you want to tell us a little bit about all the changes that are going on?
Sure. So, welcome. We have a new designee from the Secretary of Administration and Finance, Secretary Heffernan. Elizabeth joining us for the first time today. Warren Peters, who is the Secretary designee, is now working for Secretary Sutters as Undersecretary, and so she will continue to be the designee for Secretary Sutters on the committees. And so, Elizabeth, glad that you could join us today.
And just to deny the rumors off the front, it is not true that this committee was sufficiently mean to Lauren that she begged up. So I don't know where that rumor got started. It's not true. All right. So the bulk of what we want to do today is in two parts. First, we want to look at our various investment programs, and we're going to start off that with the folks from the BU School of Public Health who have been evaluating the CHART Phase 2 program, and so we're going to look forward to that. And then we're going to talk some about preliminary findings for the healthcare cost trends report, which comes out at the end of the year and for which there are recommendations that we want to be sure to follow up upon. So that's what we have on the agenda. Let me just see if there's anything else we should do before we launch into that. Okay, so let me then turn it over to the folks from BU, and then who's going to do the introduction. Okay. If we need more chairs up at the table, we can secure some. Good morning, Mr. Chairman. Why don't we see if we can all move over a little bit to make room for Stuart and for guests.
Good morning. Happy to be here to talk about the evaluation of CHART Phase 2. Evaluation is an important component in the life cycle of every HPC investment program. Evaluation is a statutory responsibility of the HPC, but we have a lot of flexibility in how we approach it. Our philosophy has been to go beyond understanding just whether or not an initiative succeeds into looking at why and how. So evaluation does share some goals with learning dissemination, but they are distinct enterprises. Where the focus of L&D is more real-time and practical, evaluation is reflective and analytical, and hence time-lagged. The next slide, please. So, as you know, we've partnered with the Boston University School of Public Health for the evaluation of CHART Phase 2. To refresh your memories and to tee up for their presentation, this evaluation was designed with a framework that was developed for the evaluation of large-scale CMS programs. This framework considers 3 domains: implementation, impact, and sustainability. This is a mixed methods evaluation that's employing quantitative analysis of CHICI case mix data, qualitative analysis of hospital site visits and surveys, and also patient interviews for the patient perspective study. And today, we will hear from the BU team primarily about implementation. As I mentioned, evaluation findings are time-lagged. We don't yet have results from the quantitative analysis or the patient perspective study. So today's findings are based on site visits, the first round of hospital site visits that were conducted roughly a year ago. So they refer to a point in time when most hospitals were reaching the halfway point in their programs. I am happy to introduce Chris Lewis, the principal investigator of this evaluation. Chris is a faculty member in the BU's Department of Health, Law, Policy, and Administration. He directs the healthcare management program, and he leads large-scale mixed methods evaluations of healthcare delivery initiatives in a variety of settings and several states. So, Chris.
Great, thank you, Jessica. Really appreciate it. Okay, we're very excited to be here today. So, and to present some of our preliminary results from the evaluation that has been ongoing now for a little over a year. And first, I'd like to start by thanking the Health Policy Commission for the opportunity to speak with you guys all today, and also for our partnership with Jessica and many of the team members here. We've gotten to know each other very well over the last year and a half, and have really enjoyed the relationship so far. So thank you all for that opportunity. I'd like to introduce several members of my team who are here today. Right to my right is Sally Bachman, who is has a joint appointment in the School of Social Work as well as the Department of Health Policy Management. David Rosenblum, who is also in the Department of Health Policy Management. Kathleen Carey, a health economist, also in the same department, as well as Alan Sager. So thank you all for being here as well. And with that, we'll jump into the interim report findings. And just to go over kind of the agenda for today, and what we're going to be talking about, I'll set it up a little bit with some process in terms of who our team is, because even though we're here and there's 5 of us, there are several others that are working on this as well. Talk a little bit about the framework, activities, and our timeline for completion, and also for the work that's been done already. Go over the summary of the findings, as well as present some more detailed information by theme, as this is primarily qualitative information that we're presenting today based on the implementation lessons and the findings. We'll then conclude by going into future evaluation activities, but I want to welcome discussion at any point over the course of this presentation, so this way we don't have to wait at the end for 10-15 minutes of questions, so feel free to jump in at any time if you guys have a question or want clarification on anything. So on 2 slides ahead, we have essentially our framework for the evaluation team, and the important thing to note here is that there are a number of different work streams going on. So we have, to simplify it, there is a quantitative aspect to this evaluation as well as a qualitative. And we have an integration team and a synthesis team that is put together and comprised of the investigators on the team to essentially track the information that's being collected and analyzed on each one of these individual teams, as well as to integrate it to understand what's going on with the deliverables, and analyze content, review information, and also keep a general timeline and make sure that we're on track for all these things. So monthly we meet and we discuss the current issues that are going on, and also think about interesting research topics that might come from this as well. Our framework here, it looks like it's a little bit small for the folks in the audience, but it's really based on, as Jessica said, implementation, impact, and sustainability. As we look across these 3 domains of the work stream that's going on in this evaluation, we have a number of lessons that we are going to be focusing on each one of them. In terms of implementation, it's what are the barriers and facilitators to implementing the projects across the 25 awards. Impact is what's getting the most, essentially the bang for the buck, and which are the activities that are becoming most fruitful in achieving return on investment. And sustainability is what are these programs doing to actually keep these projects going after the life of the 2-year demonstration program. So I think in terms of the work that we're going to be presenting today, I've put red boxes around the 2 that we have information. We definitely have information about implementation. And we're going to be able to talk a little bit about sustainability as to where the programs were at that point in the about halfway through. And this is really how we think conceptually about the process in terms of the key program components, the desired results, and where the chart goals are going. So some of the activities that we're doing, that we have done already, or in the process of, we have done stakeholder interviews. We've done 2 waves. We actually just concluded the second wave. The first wave included 235 interviews across the 25 sites. So we did a substantial amount of work in about 4 months. That information, I think I go a little bit deeper on that in a couple of slides from now, but that data collection started a little over a year ago and concluded just recently with the second round of interviews. We did the first round last quarter of last year, and then we did the same thing this year as well. We have patient interviews that we collected. We did 51 patient interviews, and this is all in related to the patient perspective study that is a component of this mixed methods analysis. Definitely wanted to make sure that we heard from patients over the course of that were receiving care from these chart teams, and we just concluded the data collection from that recently, and we're in the process of writing up the report for that and analyzing it. In terms of surveys, we've done 2 waves of surveys. Actually, the second wave is almost finished. The first wave was done last year about this time, and we have concluded a report of surveys, and also are going to be doing the same thing, comparing across last year versus this year and what we've learned since then. And then there is a substantial quantitative piece of this, which is related to the CHICI mix data that Kathleen and her team on the quantitative analysis team are going to be leading in terms of the utilization data that we're going to be looking at. And as Jessica said, at this point we have looked at the pre-intervention data, so in other words, the time period before when the actual chart implementation started. We're just now getting the data from CHIA in regards to the first year of implementation, and then soon we'll be able to get the second year of implementation So on this timeline, I think the most important thing to note is just that we started our contract or our agreement here with the Health Policy Commission in July, where they were about 9 months into when the first chart program started, and we have been able to do a substantial amount of work in probably about a year and a half that relates to, that overlaps significantly with the work that the chart programs have been doing, and we've been interfacing with them along the way. So this gives you an idea of some of the activities that we've done there in terms of when that data collection started and ended, to add a little more color to that. I spoke a little bit about this already, but I think important here on this next slide is that within those 235 interviews that we conducted at the sites, it was about 9 to 10 interviews per site. We also spoke with some commissioners, and we spoke with program officers here at the Health Policy Commission to get a rounded perspective as to what was going on at these organizations throughout the first year of implementation. At the same time, to break it down a little bit further, we had about 114 managers from the organizations that we interviewed, 91 direct service caregivers, and 30 community partners. So we involved the perspective of not only the hospital staff doing the work, but also the people who were in the community who were participating in these projects. And what we've come to learn has been a huge part of the work that they do. So what we're going to be doing now is really getting a little bit deeper into what did we find from those interviews. And just to set the stage for the next 10, 15, 20 minutes of this presentation, I'm going to essentially give you guys the cross-cutting findings that we learned across all of the interviews and when we wrote up the themes for the interim report. And then Sally's going to go into a little bit deeper into the specific, several of the specific themes that were most notable, as well as share some interesting lessons learned and examples from the facilities.
Can I just make sure I understand this right? So what the conclusions you're going to tell us about today are based on largely the earlier surveys. It says here from July through April of this year.
So
last July through April of this year.
So it's from all of the information that we collected essentially from the period of when we started through April of this year. But these results are primarily based on the site visits, which were qualitative interviews and key informative interviews that we did the last quarter of 2016.
Okay. And then subsequent to that, you've been continuing the interview, is that correct?
So we did a second round of interviews, which were essentially follow-up interviews, focused more on sustainability and other things related to the second year of implementation. So the first round of interviews that we did about a year ago were focused on how did your first year of the implementation go? The round that we followed up on was more about, okay, what did we learn over the last year, the second year of implementation and sustainability? We don't have that data to present today as it's being analyzed now in the first quarter.
And those are the interviews that you just finished.
That's correct. That's correct, yes.
As you go along, if you have any impressions based on those interviews, the more recent ones, let's say, what we're hearing sort of seems to us like it's consistent in the second year, or you might want to hold on because we heard some different things in the second year compared to the first year. I guess it would be valuable just to put those on along the way. As you said, we won't ask you too much detail because the analysis processing is all of that's totally fine. But just if you know that there are any discrepancies or confirmations coming up, that would be valuable.
Sure. Okay, so let's dive into the first set of key findings. So, and to frame this, there are essentially 6 cross-cutting themes that are findings that we took away from our analysis of these data. And there was about 30,000 pages of data once we got it coded, so it took an enormous amount of raking through this to really look at what the common themes were. But they did emerge. And the first one is really that chart teams are innovating in care delivery and implementing new approaches to known problems. And what do I mean by known problems? In these communities, there are vulnerable populations. There are patients who are high utilizers of care. That is not the novel part of what we found here. I think those topics were in existence and were known. What we found is that the chart teams were applying new approaches to try to care for those patients. And that, in the spirit of the chart program, they were really addressing these challenges, for example, with respect to behavioral health or substance abuse issues, in a more coordinated and directed fashion. So the intent of the process, from what we could find in implementation, was working. And these innovation programs were beginning to bring together different community partners that were not part of the process before, different types of caregivers as well, all under the auspices of this program. And regardless of the path that they took, the primary aim or the type of project that these hospitals tried to implement, essentially they all ended up focusing on patients with the same types of needs. They had high utilization, problems with resources and accessing care, and a number of other areas as well, which Sally will talk a little bit more about later. The second one, yes, sure.
The new approaches, are these approaches that were outlined prior to the grant or approaches that were ad hoc?
So I think many of them were, they evolved, I think is the best way to put it. So they had designed programs around using community health workers. For example, Mercy Hospital had a design where they were going to contract with an external agency to implement 5 community health workers in their organization to really go out there and kind of pay them to be out there with these patients. The vast majority of the program for the first year, they were implementing those things. Whereas other places like Holyoke Medical Center, they had a complete paradigm shift. Once they started to implement their process around high utilizers or people that were there, they realized that the patients didn't want to come to another clinic that they were trying to set up. So what they did was they actually changed the model and they went to where the patients were, from more of a clinic-based model to a community-based approach. So I think there were definitely learnings that happened so quickly in implementation. The second lesson is really that leadership does matter, and that seems kind of like a duh. But the idea is that it matters when implementing complex projects, not just when it gets going and trying to help the people do the work. These leaders were involved in the application. They were involved in communicating with the Health Policy Commission in terms of planning the programs. They were also involved in multidisciplinary meetings along the way with trying to solve problems for these patients. Many clinical leaders were involved as well. So we found that the programs that were also involved with and had relationships with community partners before the CHART program actually got off the ground a little bit smoother, as opposed to trying to forge these new relationships, take 6 months to have community meetings and do all these things, where in reality it just helped them move quickly along the way. And at the same time, their roles evolved, so they didn't have to be as involved in the day-to-day operations as the year went along, and as we've learned in our second round of interviews, they've become more monitoring and tracking and communication with their boards and making sure that everybody in their management teams outside of the CHART teams in the hospital are informed of the information that has been communicated or lessons learned or things that have happened. So their roles have evolved, but at the same time, the leaders have stayed key to the CHART program. And I think part of that too that I learned from several of these leaders was that it's the nature of the patients that they hadn't been talking about before. And the leaders understood that they were challenging across all different sections of the hospital, departments of the hospital, whereas they might not have been talking about that before. And bringing these people under these multidisciplinary teams and these teamlets to go out and go see the patients, it brought more attention across different departmental lines. And actually, I think it started to break down some silos in a number of different facilities, in both the emergency rooms and the inpatient. The third point is that care coordination builds staff efficiency. And what we mean here is that not only does care coordination help streamline communication to these complex patients, but it also makes staff more efficient. So they're not duplicating roles, not only internally, but also externally, because I'll use the example of many of these hospitals are partnering with skilled nursing facilities, and they're starting to streamline the discharge process. So now they're integrating communication, they're bringing these skilled nursing facility leaders to, or social workers to their processes, and they're bridging the gap. But at the same time, it's also requiring less work for the hospital-based folks to actually have to do, and they can share some of the workload and also focus on the things that they want to focus on. So we did generally find that across a number of the hospitals in a number of different settings. And we found it specifically related to community health workers, the use of case management and care management as well. So in the fourth bullet, chart teams have reshaped the roles of the workforce. So then the titles of these people on the slide, community health workers, social workers, peer recovery coaches, clinical pharmacists, those are not new. It's what they're doing, which is an adaptation of the roles that they had played before. And I think these types of roles, including enhanced care planning, patient planning, collaborative home visits, which include not only a community health worker, a clinician, but also a pharmacist in some cases. They're going out there and trying to help them manage medications better and figure out what's going to help them be healthier at home and accounting for their situation. And I think we purposely use the word care planning and not discharge planning because they're taking into things like housing. They're trying to better adapt for family life. What is the home situation look like? What resources do these patients need? It's not just here's your medications and we'll see you. Hopefully we don't see you tomorrow. So they're actually bridging the gap.
Who are the most common community partners you work with?
Good question. I think that the Visiting Nurse Association is one. They work with mental health providers where there was not a lack of resources. Elder Services was a number of them. SNFs, for sure. Home care agencies. In the survey that we did, there was a primary care physicians, for sure, both internally or employed by the hospitals as well as independent. Different sets of challenges with both of those based on the arrangements that they had with the hospital already. But I think the idea is that each hospital had a different set of community providers that they worked with. In our survey, we found that those ones that we just noted were the most commonly referenced as their community partners to be critical to success as they saw it.
So they're more healthcare oriented community partners than say social service.
I think that the housing groups, the elder services groups, were really addressing the non-health related needs. And in fact, it was the non-health related needs that were most challenging.
And group homes were another one that several organizations worked with as well. Quickly went through these last two on the next slide. So HIT, Health Information Technology, was a challenge for most of these programs as they started to ramp up. They weren't used to collecting the type of data and the volume of data that they were asked to as part of this grant. So it created challenges of implementation when they were trying to either put in a new system or to track data a new way. So initially those were real challenges for these organizations. And I would say 25 out of 25 of the sites that we went to had challenges with implementation of HIT. There was also fragmentation between or essentially inoperability between the community partners and the health systems, which remains a challenge today that we've heard in on our second round. So it's gotten a little better in a certain few places. Maybe they find a way, they use tighter text or some other ways to communicate with these providers, but they're not contracted social workers or community health workers. It's hard for sharing of data. That said, there were a lot of lessons learned. So we were there about a year after they started this. So some of them could actually develop web-based portals that they could track patients and pull information on a daily basis. Others had implemented Loopback, which was a system that they were able to kind of sit on top of their Epic or their other electronic health record to extract data out so they could use it better and track and trend some of these things. So I think that there was a definite sharp learning curve that they were climbing, but at the end of the day, they stuck with it. And in most of those facilities, when we talk to them now in the second round, the last year they had worked out all their problems and they were streamlining communication and looking at their dashboards and actually tweaking it to use the metrics more effectively.
So I have a general question that, about all of this. So when we went and invested and where the legislation required, the funds and the activities went primarily to community hospitals. They went to less well-financed hospitals. They did not go to the leaders, either in Massachusetts or not. So my question is, and it's not necessarily now, but as you play this one out, not only that, our staff, when they created the chart and pushed or negotiated with the teams who in fact set up the rules, pretty much had to make use of what was known by the leaders in the field, either in Massachusetts or around the country, in terms of all the things we're talking about, IT, community activities, use of caseworkers, that's whatever we talk about. So here you have a situation where you have the activities, the facilities, and so that are not the leaders in the field for the most part, with a negative. And so now the money goes to them, we push them, they learn. So the question becomes whether at the end of the day, what was really going on here is a group that is behind the curve, getting up to closer to the leaders, or potentially even leapfrogging the leaders. And the reason why this becomes really important isn't only, and I don't want to be negative, about whether it's sustainable for them, but whether in fact we are learning something that is different and maybe better than what and I use the word leaders in quotes because there are different leaders for different things. I mean, clearly IT has been around for 20, 25 years, and some of the big, more well-financed groups have been pushing it much harder than the community. So the question is, as you go forward, and maybe even have some thinking now, I know your evaluation is primarily about this group, but it would be really helpful to really understand whether we're developing a new knowledge base that in fact doesn't exist, and knowing what works and what doesn't work, or what you're doing is seeing a group that was sort of behind the curve sort of catch up a little. You see why it seems to make some sense? So as you talk about this, and to the extent that you know this, I mean, you may not, but if you've been in the field, whether you say, well, what they're doing now, yeah, it's being done before, but they couldn't do it, or they didn't, as you pointed out, it wasn't that they hit upon populations, but they're now doing things they didn't do before. But that doesn't mean other people haven't
Finish your thought.
Sure. I only have one more comment, but points. The last thing before we get into the individual teams, which may shed a little light on your question to the point that she dealt with already, that Sally will talk about, was the discussion about sustainability. At this point, the vast majority of the chart hospitals were still waiting to see what the data was telling them. They had about a year of data. There was a little bit of a lag, so they didn't have enough of a pattern to be able to say whether these things work. Many of them had operational delays in the beginning that held things up a couple of months. So trying to get a good pattern to determine whether these programs were actually meaningful to them, they were still on the fences to wait and see. That said, there was a few executives that we spoke with that no matter what was going to happen, they were going to do whatever they could to find places for these people after the 2-year window, because they believed that this was the path that they needed to take their organization, and they could use these funds to start to build a culture around change in this direction of their organization. Signature was one of them that they talked about, and there was a number of others as well that were in the PM. So that's kind of where we that was the general sense of what we got at that time. At this point, I'm going to turn it over to Sally to talk a little bit more about the specific themes that were found.
So I want to address your question. To a certain degree, I think of it as identity formation. So one of the hospitals said to me, "We're just a country hospital. We're the only thing between, the northern side of Massachusetts and Springfield, and we're important to our community." And I think some of the things that were done through the CHART program were sort of empowering them to think that they could be leaders. And many of them took that really seriously. And just a couple of themes, I don't want to go on too long. So we know, I'm looking at theme 1, we know that these hospitals are serving vulnerable populations, people who have multiple and complex medical conditions. But I think that people at the hospitals learned that they also need to pay attention to social determinants of health. They need to pay attention to behavioral health, substance use. And I think prior to the CHART program, many of these hospitals were sort of thinking about frequent flyers without really thinking about why that is, and empowering themselves to go out into the community and figure out how they can develop partnerships to make a difference. They use things like using the data, really using the data with reports, with daily reports, so that people on the CHART team would know who would come into the ED, that they would have a plan with the nurses in the ED or the staff in the ED to flag those patients, and all of these things are kind of simple tasks that probably leaders in the field already do, but the hospital don't know. Does that address it well?
Yeah. The question is, do they learn it all by themselves, or did our team help them think about it, or did they go to places that already doing it?
I absolutely think the program made a huge impact in helping them in this identity formation. So they would complain a little bit around the edges about the number of requirements for IT measures, for example. But then when you ask them, are you using the data? Yes, we're using the data. How do you use the data? We look at a report every morning. What variables are in that report? Complain about the number of variables, but they were in the report and they were using them. So I really do think that the program had a big impact in terms of getting these hospitals to think differently.
What sorts of things were they doing in reports? Can you just keep that example going?
Yeah. So one important thing was that patients who were part of the target population were identified. So that was a big deal. How long it had been since they had last been in the hospital. Whether or not the phone calls had been made after their last discharge. Community partners that they were working with. And I don't have the set of measures in front of me that were required as part of this IT transformation. But those are an example of the CHART program pushing the hospitals to gather data that they would have gathered otherwise and to actually use it. So, should I keep going? So a couple of, I don't want to go too deeply into these examples. You can take a look at that. But a couple of the themes that I want to point out. One, the hospitals were actually using transdisciplinary teams. So, for example, going back to the ED, one person on the CHART who was part of the CHART program told me that the staff in the ED didn't want to have to tell them when chart patients were admitted. And so there was a lot of work done inside the hospital to kind of get people, motivational interviewing to get people on board with the idea of we're not going to, take over your role, but we're going to work together to hopefully prevent hospitalization. And the chart staff did this with community-based team members, people who were in behavioral health, substance use. Many mentioned elder services or the APRCs that were partners. We've already discussed a little bit about the behavioral health issues that came up again and again, and the substance use problems that patients present with. That I think in the past, possibly the hospital staff would kind of say that's not so much my problem, substance use, and then with the lack of resources around substance use treatment, it's a problem almost everywhere. But the chart staff are taking that seriously and really trying to think about innovative ways to make sure that patients are getting their treatment. A couple more points that I want to make. Theme 5. So as Chris mentioned, there were all kinds of new workforce models that were developed as a result of this program. Community health workers, care navigators, more use of social workers, more use of pharmacy, and even pharmacy going out into the home. To your point about what we're finding in the second round of interviews, some of these roles are not easily reimbursable through typical fee-for-service reimbursement. Theoretically, through an ACO model, you would be able to use bundled payments in order to also support these other types of providers. But this is a concern for the hospitals. So they like having community health workers. They like having these connections into the community. But in the interviews that I did in the second round, they're starting to chip away at that because they can't figure out the reimbursement for it.
And if I could just add, there's no great confidence that the ACOs will produce any kind of surplus that might be used to fund these programs. So they're really quite pessimistic about the sustainability of these non-reimbursable positions, particularly if they lose short-term fee-for-service revenue by succeeding in keeping them out of the hospital. So they see a double hit.
We've already talked a little bit about bridges to community-based resources. We talked a little bit about information technology, and then thinking about implementation and sustainability. Another more recent finding is that the hospitals are very interested in the mass health ACO. It's a conversation that many of the hospitals are having conversations about being involved in that ACO, even if they have a relatively low proportion of mass health in terms of payer mix. So they're thinking about the ACO, the mass health ACO as another framework moving forward in terms of innovation. So I think that maybe I should. I'm sorry, say it again.
That's not
No, I don't think so. Well, I shouldn't say no. I think that's a question.
So between Medicare and Mass Health, you see all the rest, they still don't feel there's enough dollars.
That's my takeaway.
I think that they are skeptical that there's enough dollars, and they're skeptical that the reimbursement rates will actually be adequate.
And keeping in mind in the context of reduced admissions.
If you do the math, are they right that it doesn't work out, or would it work out?
don't think the math can be done yet, because I don't think they have what the prices are.
So the issue is reduce revenue and reduce costs.
That's what they're
But
worth.
there's savings, right? So it helps you meet your ACO targets. So it doesn't seem like, I mean, granted, you need to know what the reimbursement rules are like, but once you know that, you can actually do the math. It's like, well, it's in your interest to keep this going, and it's not in your interest to.
Well, yeah, I asked one hospital, the other thing that I want to say is I thought the hospital leaders were very sophisticated, very knowledgeable, were really able to have high level policy conversations. So I asked one person that I asked that question to said, well, our only choice is to team up with the leaders.
So here, as you talk to them or as you look forward to them, to what extent, if any, is there a restructuring within the system itself to the point where some of these activities no longer become add-ons, be funded only by new revenues, but in fact may be preferable and more important than activities they were doing before? So, I mean, what David said, I'm very concerned about. I think over time, we're already seeing it, a reduction in the rate of growth of revenues, and potentially even a reduction in actual revenue and hit the health system and hospitals. And unfortunately, there's also a backing away from the ACO type approaches. So the point is that if any of these are going to survive in that environment, where some leader can say, all right, I have less revenue, even if I don't have more revenue than I may even have less. These are so important in providing care to patients that if I'm going to take costs out of the system, I'm just not going to take. And this is a hard thing to do because they're the newest things, as you pointed out. Often they are areas that are not being reimbursed in fee for service. They are nice things to do in the community, but they're not what is generally considered to be the core activities of the health delivery. So this is a tough issue. So as you look in the final stages, the question is whether there's going to be any shift. See what I'm saying?
Yeah.
Let me respond directly to that and to the broader question that you raised about whether they're learning to catch up, something new and different, better than the so-called leaders. I would start by saying there's a general consensus out there that these organizations have a very limited capacity for risk. And so while in theory they might be better off to do this or that because it's going to pay off, risk-taking is very hard to do with very narrow margins. And so I think that the risk-taking capacity is and so I think they really did learn many new things that teaching hospitals perhaps they were taken for granted for a while, whether they do well or poorly. These are not new concepts, and to some degree, these were new concepts. I think the learning curve was steep and fast, particularly as they came. I think some of them came to be quite surprised at the depth of the social, housing, hunger, mental illness problems of their patients, particularly the people who turned out to be showing up at the emergency room because they were hungry. That, I think, was a surprise as they got into it. They learned quickly. But at the end of the day, the tools they had to apply were still the tools that had been developed by the leaders. They didn't have a whole new set, a whole new toolkit. I think that as they began to go out into the communities, the question is there something new and better that they might be evolving that the leaders have. I think that some of them found that the partnerships with the community agencies were a real possibility and a real perhaps opportunity, and not, but how to hold each other accountable for actually providing the services that are supposed to be provided. I think that we're quite tentative about, is the hospital going to take on the leadership to hold these community-based organizations mutually accountable for actually delivering services in a risk country. And I think that if, in small communities, there might be a sense of community developed where community accountability actually helps over the long term, which may be harder to achieve in a large setting. But I saw a lot of tentativeness about whether they were really going to commit to the concept.
I just want to, because I keep thinking in terms of dollars and cents, and be wrong for something. Because he asks these questions better than I do. Right. There ought to be a financial model at the end of the day that is either a go or no, that we can say to them, actually, if you do it right, it's a go, or if you do it right, it's a no-go. Just like this is how paraphrasing. So, like, I would love to know the answer to that. Like, pick the research that they're putting in place, and they need to save it, and calculate what that's going to do. Medicare ACO product, it sounds like many of these are seniors, so Medicare ACO product, and that's how they sort of take most of that. Below 65, somewhere. And you just sort of took that, would you continue to present that? I don't know, I mean, maybe it's too soon to know the answer to that, but it seems like that would be a valuable thing to be able to say, look, you did this. And actually, at the run rate, given what you can expect, this is actually a good financial decision, let alone it's a good community decision and partnership with people and so on. This is actually something that's a good financial decision for you too, now that you've had 2 years of experience.
And I'm not sure I have a great answer for that today, but I think that's something that we can certainly look at a little bit more as we move forward. And I know Kathleen and I will, our quantitative team will certainly take that and see what we can look at in terms of getting you some feedback.
I think that's a marginal issue. That's a very critical issue because when I look at the last bullet, sustainable, it's just too early for most hospitals to know. From what I'm hearing from you is, and this is frustrating, the program appears to be successful. The problem is you're talking about organizations that have margins of 1% or less in some cases. And if it's going to reduce revenue and also increase costs, it's not sustainable. So the question becomes, how can we help these folks look at this and take the next step, as my colleague just said, looking at the financials? Because quite frankly, if you think about it, whether you have another year left, 6 months left in the program, if it doesn't work financially, you're not going to do it. And you're already thinking about what you're doing next, and you're moving on. That's just reality. I think we need to help see what we can do to show viability, financial viability, because they do not have the cash on hand. They don't have the margins to basically sustain a program, regardless of how successful it is, if it's going to help put them out of business. And that is an issue for these firms.
And it's an urgent issue with respect to sustaining what they've learned, because some of them are shutting down. Quite ironically, one of my students actually worked for a Chart hospital, and she told me yesterday that she was going to the going away party because her hospital had decided they could not afford to continue the activities that they had set up. Now, the question of whether that hospital could have redesigned some existing internal process. You know, the one that I saw and heard about in several of the interviews was perhaps redoing their internal discharge planning and case management functions to be more outward going, be more outward reaching. But you know, that's something.
So just a couple of responses to the commissioner's questions here. One, would just highlight again the results that are being shown here from a year in. And in the year since then, through our grant, we provided every single hospital $50,000 to do sustainability planning. And so they actually went and did that exact work that you guys are talking about to figure out how they could make this work for their organizations. And we felt like they need to help, do that type of calculation. And what we found, and so we have all of their reports, they provided them to us around how they did the sustainability planning, what came out of that process. So that is a whole work product that we're going to have a lot of insight into exactly how they thought about this. Two, I would say what we've heard from hospitals is that this is not just a financial calculation. That there is a sense of doing the right by their patients, the organizational changes, the culture changes that have occurred through these programs. Many hospitals are finding other resources to try to keep these going. So it may not be the same patient revenue, maybe philanthropy, and maybe through fundraising, and maybe through reserves. They're trying to find ways to keep these programs going. And I guess maybe we're hearing a little bit different from what the BU team is hearing, but we have information that indicates to us that 91% of these hospitals are continuing the CHART projects in some form, even after the program ends. So to us, yes, they might be scaling down in some cases. Yes, they might be focusing a little bit on a different population. But there's other institutions, to your point, Chair Altman, who are no longer viewing this as some add-on program. They're not talking about it as CHART anymore. It's just how we deliver care. And they're being incorporated and kind of hardwired into the hospital, and they don't even talk to themselves as the CHART team anymore. They're the patient care team. And so there are, and it's variable, and it's not for every one of these hospitals. And the last thing I would say is, we had planned and hoped to have a final phase of CHART funding. We had thought about this as a phased program where this $60 million would not have been the last phase, and that there would have been continued funding for potentially another year and a half to create some of that bridge to sustainability. Unfortunately, those resources aren't available to us anymore, and so I think for many of the CHART hospitals, they were looking to see what is this bridge going to be. And in terms of the ACO and the Mass Health ACO, I think there is a lot of unknown still. And for some of the hospitals, I think what we know is that they've made a commitment to say, we're going to keep these staff on, we're going to keep these programs going for another year. And then we're going to reevaluate and see, once the Mass Health ACO gets going, can we make this work in financial model? So I think the experience isn't as black and white as everyone shutting down, nor is it everyone is continuing, at full 100%.
David, at least from my point of view, we really haven't talked about this. And I would also love to get the evaluators into this as well. I think we ought to develop what I would call a nuanced definition of success and failure. And you guys have been at it. So what I mean by that, without knowing exactly what I mean, we need to play this one out. To the extent that there's not sustainability, but it's really not the fault of the CHART program or the hospital, but external forces, we ought not to necessarily consider that a failure. And so maybe, as I said, as you think about this, think about what I would say nuanced success or failure. A failure would be, a hospital that either didn't do it didn't implement it, it didn't really like what it was doing, the forces of evil in the hospital overwhelmed it. I mean, you could play this one out because I could play it out myself. So that's a failure. But a success might be a program that was being implemented, there was support for it, and then all of a sudden the financial house fell apart, and they don't sustain it now. So I'm just throwing that out. I think we ought not to, pat ourselves on the back all the time, but on the other hand, we should not beat ourselves up for activity that really were outside the control either of us, the program, or the hospital. Make sense?
A 91% adoption rate in some form is very positive. The question becomes, when we look at that adoption, will it generate the types of results we're looking for? So we really need to analyze that. But I think that's a very positive statement that 91% of grantees are looking at some form of option.
And the run rates in terms of may change. And so I think some of our experience is that in the first year, even the first 18 months, it's a lot of resources to set this all up. And some of the hospitals are saying, we can actually think we can continue to get the same impact, maybe with 3 staff instead of 6 staff, because now they've had this experience and have all the things implemented in place.
So I want to be respectful of the committee's time as well, and I want to look forward again to the future evaluation activities, kind of building on the conversation that we've been having. So we have, we're shifting from a lot of the data collection from the actual hospital, the surveys and the site visits, to more data analysis with the case mix data that we're going to be using from CHICI. So we're going to be looking more at the utilization data and other things as well. So I think that's something to look forward to. We look forward to coming back and continuing a conversation with you guys related to some of those results that we find over the next year, and keeping that line of communication open. And we'll certainly take back some of the feedback that you guys have given us and the ideas that you've given us today, and consider that as we continue to evolve the evaluation activities. And thank you for the opportunity to speak with you guys out today.
Can I just make, before I let you go, can I just make one comment or one request on the quantitative implementation, on the quantitative evaluation? It would be very helpful to see what the private impact is, that is, what is the impact of the hospital and the system that the hospital is a part of. And then second is, what is the social impact? And those may differ because, for example, there may be savings to mass health that are not realized by the hospital, but that are realized by the Commonwealth. So we wouldn't want to say the program is not financially successful if all it does is save the Commonwealth a bunch of money, but doesn't include the hospital as well. By the same token, it's not nearly as successful if it creates, if for some reason it created a lot of profit at the hospital that didn't seem to benefit anyone else in society. So I really care about both of those dimensions here.
Thank you guys again. Really appreciate it. It's great. Thank you.
So we're gonna switch gears and talk about future investments. I think it was really, really helpful to have the evaluation conversation precede a conversation about what the last $10 million that we have in our trust funds can possibly be expended on. And I think, really exciting work that you just heard about going on in the delivery system, transforming around social determinants, behavioral health, substance use disorder. Those are things that we feel really strongly that we want to continue. And we want to continue to build that evidence base that you all are looking for, which is there is an evidence base for the return on investment of healthcare institutions investing in social determinant and behavioral health interventions. Right? That's sort of what the world seems to be seeking right now. I'll also say before I turn it over to Margaret, who will take us through the presentation, through our ACO certification data, in addition to the strategic planning data David Seltz mentioned, we have all Mass Health ACOs certification applications in-house, and a majority are talking about their CHART program as their population health management program, right? So it's not in the hospital setting, but it's in the ACO setting. And that, that's exactly the trajectory that we had hoped to see in this program, and thinking about how a Mass Health patient population through the Mass Health ACO program and the district funds could potentially continue to be served. The delta of the all-payer patients, again, sort of giving it a little bit more time to see how that plays out. So I'll turn it over to Margaret, and I'm happy to take any questions at the end.
Kathleen's going to jump in before Margaret. Margaret will be allowed to speak today. I just wanted to also note for the commissioners that at the board meeting, next week, we will be giving more real-time feedback on the CHART program. Again, the VU external evaluation is a very important component of the overall CHART program. And the findings that you heard today were at a point in time at about a year and a half ago. And we want to report to you more real time on some of the performance data we've seen, some of the lessons learned. We want to talk with you more about the care transformation activities that have happened. And so we look forward to diving into that and probably having some of the similar questions and discussions with the full board next week.
Thank you, Kathleen and Katie. So today we'll walk you through, again, our proposed recommendation for this next investment program, finalizing the funding from the Distressed Hospital Trust Fund and the Payment Reform Trust Fund. And so, as you know, this proposal reflects extensive stakeholder input as well as feedback from this committee from the October 18th joint meeting, as well as the November 1 board meeting. So today we'll be asking the committee to vote to endorse this framework and to recommend that on next week's at next week's board meeting, the commission authorize the executive director to issue an RFP accordingly. Okay, so this $10 million investment proposal aims to reduce avoidable acute utilization through programs addressing social determinants of health and behavioral health, programs that are community-based and reflect strong partnership. Each award will be capped at $750,000 in HPC funding, with awardees themselves contributing 25% of program expenses. Competitive factors fall into 4 areas. First, the strength of the proposed model itself. Second, factors about the bidder's organization, the leadership, connection of the model to the applicant's overall strategy, and the applicant's need for funding. Third, the strength of the applicant's own proposed evaluation plan evaluating the program. And finally, a credible plan to sustain and scale the program if it proves successful. As applicable, proposals will aim to reduce many forms of acute care utilization, increase engagement in opioid use disorder treatment, and improve patient experience. And as we've said, eligible entities are HPC certified ACOs and their participants, and CHART eligible hospitals. So,
Answer the question about
please.
the competitive factors.
Yes.
I think last, I'm going to be broken record on the engagement of the workforce. We talked about this at the last board meeting. I think the presentation that we just heard highlighted actually in the final recommendations or conclusions the important role of both the care coordination to build staff efficiency and renewed engagement of the workforce. I think there's probably new engagement of the workforce in a lot of respects. So I'm wondering how, that we just had a great presentation about the important role the workforce plays, new jobs, care coordination, efficiencies. And I feel like it's a very important factor for taking consideration for new applicants of how they're engaging their workforce and the care coordination teams, all the different elements of it. So I'm wondering how it's reflected in the competitive factors or in the application process of how they're engaging their workforce in this the last phase of this project.
So in one respect, we are asking applicants, we plan to ask applicants to tell us a bit about the governance of the programs and asking the extent to which staff, as well as patients and families, contribute to design and governance of these programs. That's one area
Yeah, I mean, we're asking questions about it, but it also, these are sort of the rolled up competitive factor domains. There are a lot of bullets in the RFR under this, and at the board meeting next week, we hope to be able to give you a draft of that RFR so you'll be able to see more clearly that engagement of frontline workforce and patients and families in this particular domain around organizational leadership strategy.
Okay.
Yep. So we're definitely looking at it and appreciate that feedback.
I'm curious, in looking at the outcomes, there seems to be one outcome that isn't in there that I really think we should, which is, and I don't know if it's too late or not, but what's not in here is some internal restructuring of the delivery system to lower costs. So you have a number of utilization issues that have the potential to lower spending, and those are great. Then you have a couple that have the potential to improve quality, which are very nice. So the question is whether you can or if it's too late. But in other words, we talked about it just now. We are a hospital in the process of doing things, restructures its intake system, make use of IT in a way that actually begins to focus in on spending internally that really doesn't need to happen. So to the extent that you can, because after all, that's what we're partly all about.
And these are all, as you know, these are all facets of that sort of structural change that we're seeking.
Yeah, but they're not in these four.
It's not in the outcomes, and I wonder about what we could be asking things to accomplish in an 18-month time frame.
Now the question is whether they did it. I mean, they may be doing it, or if you want to put it in the second, you just don't want to lose that thread that somehow the chart program is independent of part of, I understand the value of reducing utilization and potentially waste, but that's half the equation, and over time, actually a smaller part of what we're spending than the price side. And in order to get at the price side, you gotta get at the cost side. So, I mean, I bring it up, and maybe we should have talked about it once, but in the process of doing this, you can find that it would be next week. Be better.
So it's a really good point, Chair Altman, and I would note in the chart program, we've actually been really explicit about this. So for the grants in the chart phase 2, we actually held some of that money at risk, depending on if they were able to achieve some outcomes that we were looking for. And we basically, that outcome that we were looking for was, yes, were they successful in driving down some of these utilization trends, things like ED visits and readmissions. But we also evaluated, have they changed some of their internal structures? Are they engaging patients in different ways? And those aren't the same kind of quantitative elements, but we came up with a structure to evaluate, have they actually changed the way that they're delivering care and actually held some of their money at risk for those things as well. And so it was not just around kind of driving down utilization, but it was around organizational changes within.
So I'm just saying, I wouldn't. I just think we're going to be on record as putting that as
Yeah, I don't think it's too late, and I don't think that's inconsistent with what we've been talking about here. The challenge for me is that this isn't a price variation investment program, and I think cost is. It is a restructuring, and we're targeting the utilization part of cost, and we're not getting at the price element of
I understand
cost.
the price.
Okay.
Because that's not what I'm talking about. I'm talking about cost.
And efficiencies of systems, and that absolutely is an element, and part of the reason why I agree, and so I think it is entirely consistent thematically with what we're trying to do here, and that is why we are requiring these relationships with ACOs and having ACOs be the eligible entity, and even if the hospital is the one getting an award, they have to demonstrate that they are part of the system for these exact kind of efficiencies of system, and that you're not developing a chart team at the hospital and you're developing a population health management program at the ACO, and that is inefficient to system restructuring. So we can take that feedback and think about it a little bit more.
Thank you for the questions. All right, we proposed 2 tracks, and so as we said before, for the first track, we seek bids for programs addressing social determinants of health in order to prevent future acute utilization, requiring partnership with social service providers and community-based organizations as part of the proposed program. For the second track, we seek bids for models that increase access to behavioral health services at the point when the patient needs them, again with the goal of preventing future acute utilization. So open access programs, real-time programs, and noting here for medical care provider applicants, an outpatient behavioral health provider partner is required, and for BH provider applicants, a medical provider is required, again stressing partnership. We do call out a specific focus on opioid use disorder treatment, seeking bids from hospitals to further test ED-initiated pharmacologic treatment for substance use disorder, aiming to increase rates of engagement and retention in treatment. Questions about the tracks, please?
Yeah, Margaret, I have a question I'm trying to get my head around. This sounds like a lot of what we also funded in chart phase 2 that we just heard a lot about. And I'm wondering, are we funding continuation of existing programs, modifications of existing chart programs? Are these brand new initiatives? I'm just trying to figure out.
Sure, I think there are components of chart programs that may well fit in some of what's described here, and as the prior presentation noted, there are absolutely components of chart programs that address social determinants of health, but perhaps not to the extent that's really warranted with these populations, and so kind of pushing the needle in that direction.
So some of what we might fund is just enhancements of things that we may have funded in chart phase 2 or we initiated, and for example, in terms of addressing social determinants, I guess, and taking it another step. Is that?
I think we'll have to see what we get, but again, if there's a chart team that can sort of demonstrate that chart hospital that's had a program that addresses one of these factors, and they can sort of persuade us why further funding is warranted and needed according to the goals of the RFP, that's something we certainly do.
And I would just note that if a chart hospital applied and that chart hospital is part of an ACO, we're going to want to see that relationship, right? So to the point that was made earlier, let's not set up a whole care coordination infrastructure at a hospital. Let's set up a whole care coordination infrastructure at the ACO. Let's ensure that there's some coordination and alignment and the appropriate utilization of resources to address the needs of these populations. We know that there's a small subset of our chart hospitals that are not part of an ACO, and so obviously want to ensure that they have opportunity to continue or pursue work to reduce acute care utilization outside of an ACO arrangement. Does that
Yeah,
help?
that's helpful. Thanks.
Okay, and so in some, programs will run for 18 months, preceded by an optional 3-month preparation period. You can see our timeline. Next week, we hope for a board vote to issue the RFP, followed by an early January RFP release, 2 months for response development, and again, looking for a mid-April board vote on programs. So with that, happy to take additional questions.
If there are none, then there is a motion on page 50, which is that the motion is that the committee endorses the proposal for the investment program as laid out. And then this would then be voted upon at the board meeting. To be voted upon at the board meeting next week with the idea that the committee has endorsed it.
And we plan to release the RFR after the new year, just given the holiday time, we plan to release it on January 18th.
Okay, does anyone wish to motion? All those in favor? In opposition? Or abstention? Very good. It's unanimous. Thank you very much. Okay. So let's shift gears a little bit to turn to the cost trends report. And hear both about what it's going to be like and about some of the selected findings. David, are you going to lead us through it?
Great. All right. So switching gears, as Commissioner Cutler said, we're going to move on to the 2017 Healthcare Cost Trends Report. So this is our annual comprehensive report as mandated in statute. The approach that we've taken this year is consistent with what we've done in past years, which is to basically split up the presentations to the board. So what we're going to do today is do a deep dive on some new analysis that we've run. At next week's board meeting, we'll also go through kind of an overview of all of the findings for the board and for the public. And then at the end of January, at our next board meeting, at that point, we'll have a full written report with recommendations and plenty of time for input by the commissioners. So we kind of do this a little bit in stages in order to allow you guys to provide feedback and input to us as we track towards having some policy recommendations in the final written report. So I think fair to say we're going to do a deep dive on something that is new today. We'll do some of the same findings at next week's board meeting, but kind of roll it up to a higher level because, as you'll see in a minute, we do get quite into the weeds on this particular topic. But before we do that, I wanted to just highlight for the commission and for this committee and for your input and feedback a little bit of a redesign in our approach to how we're thinking about cost trends research and reports. We're 5 years in at the Health Policy Commission. I think we've learned a lot through this line of work. Our previous approach to date has generally been that we produce one comprehensive written annual report that can be upwards of 100, sometimes 120 pages. It is a written report with graphs and charts, and that covers a broad range of different fully written chapters. We've been able to supplement that comprehensive report with some other big publications. For example, the Community Hospitals at a Crossroads report that we did a few years ago. We did a whole deep dive into provider price variation. What we're proposing as a little bit more of a revised approach is a little bit of a smaller annual report and moving more from just kind of a written text report to one that is more graphical and more visual and more engaging in terms of the audience. And so I think this is consistent with where a lot of this work is going now. I think a lot of research organizations, including our sister agency CHICI, are moving away from these kind of big, huge books of written text and moving more towards how can we use the data, display that data in engaging ways for a variety of different audiences. And so what we're proposing this year is instead of a 100-page report, something more like 50 pages that will still have a couple of deep dive areas, but will also be supplemented by a number of kind of chart packs and graphical supplements on some areas that we've continued to track. Things like avoidable emergency department use, post-acute care, readmissions, and the like. We're also experimenting a lot with new ways of putting this on our website. Again, using tools where people can go in and manipulate the data themselves and think about how they want to put together some of these graphs and look at the data and be able to interact with the data. We think this is, our experience has been, this has been a good way of getting a broader audience to this work. And then with kind of some of the freed up capacity from not doing a huge annual report, be able to do more frequent reports throughout the year of varying sizes and lengths. And so thinking about doing you know, a 4 or 5 page policy brief, a chart pack, even things like a short blog post or data points that we would parse out throughout the year. And so I think we're excited about kind of innovating in how we display and engage audiences on this information and making it more accessible. So that's a little bit of the revised approach that we're going to be testing this year. And you'll see on this next slide, this is the outline for our 2017 cost trends report, and it does follow that new design approach. So we'll have, as we do every year, a pretty significant chapter in the report around our performance against the benchmark, what are the deep dives into some of the different component areas that have led to that growth, look specifically at pharmaceutical spending trends, employer premium trends and market trends, and patient access and affordability. And in terms of 2 deep dive areas that we're going to have kind of fully written chapters around this year, one is around outpatient spending. This was a main driver of spending in this year. Second only to pharmaceutical spending was outpatient spending. So we're going to do a deeper dive here looking at what is driving outpatient spending and the shifts in care that are occurring both from inpatient care going to outpatient, but in many cases that is going to hospital outpatient facilities, and shifts in care from community physician practices that is now moving into more expensive hospital outpatient. So we see 2 different directions. One is a cost savings direction, inpatient care moving to hospital outpatient. One is cost additive, community or physician-based care moving into a hospital outpatient setting. And we'll be able to show what are some of those differentials in cost that occur based on different sites of care. The second major topical chapter is around looking at major provider organizations in Massachusetts and their variation in performance across a number of different statistics, and that's what David and the team is going to walk through today. To supplement that written report, you'll see there that, again, we'll have these supplementary chart packs on topics that have continued to be a focus to the Commission. You can see them listed out for you. Again, we'll always create that dashboard that we do of, summary performance, and we'll have some recommendations. So with that is just a little bit of kind of the approach we're taking this year and the draft outline. Interested in any feedback from the commissioners on that, and if some of our new approaches here make sense to you all.
Well, for one person, this is great. I mean, I think you're right on in terms of hitting it. The one thing I would just throw out, I just recently read and using a new article that was, you may have seen in JAMA, which went and looked at overall spending changes between, I want to say, maybe you've seen it between 2006 and 2013, and basically showed that 63% of the growth, as I remember it, 63% of the growth in spending was either in price increases or in intensity. And actually utilization fell. The actual utilization growth is actually negative in that period of time, utilization being new services. And so you had 63% was price and intensity, then you have population growth and some aging. Those are the three positives. And the negatives was utilization. And it's the reason why I keep harping on its prices but intensity. And I think the way you laid it out is exactly. It's the when you talk about intensity, would be taking someone, as you said, from the physician's office and sending them into the hospital outpatient. It's still getting the same service, but it's intense. Or using a higher priced drug to do the same thing that a lower priced drug does. That's price, but it's also intensity. So as we think about this and we focus in, I go to really a very detailed study and something that we may want to look into as we look into it. So.
I think it's a great point, and I think among many of these, especially in the outpatient spending chapter, you're going to see exactly that type of analysis and thinking about the price continuing to be a driver for care here. And the one thing I would note about that particular JAM article, which is something that I think we found particularly interesting, they had kind of a one-page summary of their findings, but then also had a really interesting supplemental on their website where people could go and click on different major categories of service and could see some of the underlying trends. You could click on outpatient spending, and then within that, basically as a reader on the website, go and really be able to manipulate and look at all the data. So again, kind of complementary to some of the things we're trying to do, which is put some of this data and let the public be able to interpret it and manipulate it, and so it's something we're working towards as well.
Yeah,
All right.
Yeah. Sorry. Two quick things. One, I was wondering, I think this covers a lot of the main topics and the really good process you've outlined here. I think it captures a lot of what was discussed and focused at the cost trends hearing. I think there's one big area that's not captured or maybe captured somewhere. I'm not going to say workforce. You thought I was going to say workforce. Is around the past transactions that have been approved and their impact on spending, and the things that they said they were going to happen, the savings that were going to occur. That was one of the main, one of the bigger panels we had, and I'm wondering where could that fit into some of the cost trends reports, or maybe it's the supplemental charts of prior transactions and things that were supposed to have happened with this merger, driving down costs, all the things that we're told, and actually what happened. And I'm wondering how that fits in, if that's one of the areas that we could think about. And then are the supplemental charts going to happen with the report, or that's throughout the year, and is there flexibility of coming up with other supplemental charts based upon new issues that come up or new trends that we see throughout the course of the year?
So flipping back to this previous slide, the post-transaction review is absolutely a huge part of our continued research agenda. How we publish or issue some of those findings, I think is still up for discussion. I think we have thought about it less in kind of the annual cost trends report, but maybe in one of these supplemental publications, having a policy brief, maybe 10 pages that looks specifically at this and highlights these findings. And I think to your point, there's two supplementary things that are being talked about here. One on this page, just for the 2017 cost trend report, the supplementary chart packs you see here will be released at the same time as the cost trends report. But when I flip back to this previous, where I talk about supplemental publications and policy briefs, chart packs, data points, all of this is very much flexible in terms of what are the topical areas of interest of the commission. So, for example, we've piloted this in the past year. We did a data points specifically looking at oral health related emergency department utilization. We did one that looked at the impact of the Affordable Care Act on out-of-pocket spending for contraceptive coverage. We did an analysis on out-of-network billing. We did a chart pack on ED boarding. So I think what we hope to do is be able to hit a number of different topical areas that are of interest to the commission and are in line with our mission, of course. And that would be something where I think for next year, as we think about 2018, what do we want to put on the docket in terms of the topical areas that are of interest? That's something that we would come back to this commission and say, and this committee, and say, what do you think we should be looking at in the next 12 to 14 months that falls kind of within some of this additional topical areas of interest? Facility fees, out-of-network billing, some of these things that we've been talking about.
So as David said, for the next half an hour or so, we'd like to introduce a new and growing area of research and have a deeper dive on this topic of performance variation among provider organizations. And some of this will be in the cost trends report this year. Some of it will be talked about in next week's board meeting, and we hope to release a lot of the information via some of these new data visualization tools, such as Tableau, when the full report is released. So we wanted to go into depth as to what's behind this area of work. So this is continuing in the line of understanding variation across provider organizations. And I'll say that in years past, we have done a lot of work in this area, partly looking at hospitals and variation in prices and in costs for hip and knee operations or maternity low-risk episodes at hospitals. And last year, we noted that we really would like to go one level back and look at the larger provider organizations that patients are getting their full range of care from, think of ACOs, and how they compare. And this is more difficult. And last year we showed some of the total medical expense data across these organizations, but we had to really rely on the payers reporting this data to CHIA, and then we manipulated that data a bit to show this variation. We really were limited in what we could do, and this year we've been able to realize one of the underlying goals for collecting the RPO data, the Registry of Provider Organizations, is to be able to link that data to the all-payer claims database, and then to use the full power of the APCD to collect and create the outcomes that we were interested in, whatever we wanted that we can see in the claims, and then report those back at the level of these provider organizations. So I'm going to go through in the next few slides how we do that. I'm happy to have Natasha here, who has spent the last year of her life focusing on this, and she's back from maternity leave right now, which is great. So
she has other focuses as well.
This was her first baby. And just to preview, once this linkage is created, we can really report on an unlimited number of things. We can look at price variation, we can look at spending by category of service, which we will show today, differences in utilization across these provider groups, referral patterns, you name it. So the order of the talk today is first we will talk about how we do this assignment of the patients to the provider organizations. Then we'll show some descriptive statistics of how these organizations compare. And then we'll show two different categories of results. First, we're going to roll these organizations up into the broader structural types to test some hypotheses there that structure matters. And then look at some results by org, and how they compare, and then talk about some of our plans for the future. Okay, so the first section, how do we do this? Here's a diagram that graphically illustrates what I'm talking about. So start on the bottom level and imagine we have these patients in the All-Payer Claims database, several million of them. And we can observe in the APCD, every time they get a service, what provider did they go see? So this linkage is really done by way of the primary care provider. That's the key, these PCPs. And I don't want to say physicians, those also include nurse practitioners in some cases. So we can observe the patients, we observe who is treating them, and we are able to link them to their PCPs by a number of ways that I'll get into next. And the PCPs also are observed in the RPO. The data that we collect from the level of the provider organizations, they tell us who their PCPs are. So that is the key linkage, and you can see them across the middle. Once we know which PCP, which patients go with which PCP, and then which PCP goes to which provider organization, we can now take, for example, the orange group there, and take all those orange patients and average their spending or their utilization or whatever, and then that is now the outcome for the orange provider organization X. We can compare it to organization Y, for example, based on the outcomes of their patients.
David, I just have a quick question about the APCD. You know, there was that court decision, I think almost 2 years ago, where self-insured employers couldn't be required to report.
That's right.
Is the APCD still a credible, I mean, is it thorough enough or inclusive enough?
Great question, yes. That will start to have an impact starting in 2016. Today we're going to report 2014 data, and we have the 2015 in-house, which was unaffected by that decision. But starting with the 2016, we lose probably most of the self-insured, which is maybe roughly half of the patients. That's true. So what we plan to do this year is to really look at the self-insured group and the fully insured group and see, well, are the outcomes for the fully insured guys really representative of the total? Is that still giving us the same patterns, even with this loss that's going to happen? So hopefully the answer is yes, but we'll have to evaluate that carefully. Okay, so just finishing up this slide, you'll notice on the right, we couldn't attribute everybody to the group. There are some patients who have a PCP in the data, but that PCP is maybe in a small practice that wasn't captured in RPO. So those are to the side. Some patients don't even have a PCP. Maybe they had no business at all, or they just had one specialist visit. So they are also not going to be in this final data set that we're using for analysis. Okay, so now I'll go over in a little more detail exactly how that works. There's 3 steps here. The first step we started with is defining first who is our set of PCPs in the state that are going to be the key to this linkage. And we obtained about 7,700 from the RPO. These guys self-identify, I am a PCP. And we supplemented that with this commercial data set called SKNA that is a purchasable provider database that this company collects. And that the main benefit there was they also capture nurse practitioners, which were not captured in the original RPO. And some patients do have NPs as their primary care providers. And SKNA captures what larger organizations NPs are in. So once we have our PCP file, and by the way, those physicians in the SKNA are identified by, they know what their specialty is. So we have the specialties there that we called a PCP. Okay, so most of these are coming through the RPO, about 78%. Step 2 is how do we then attach the patients to these PCPs? Well, fortunately, about 46% were done for us. When the payers report their data into the APCD, a lot of patients are in an HMO. The payers know who their PCP is, and they flag them for us and tell us. So that's the easy part. Beyond that, then we have the hard part, which we spent a lot of time doing, And we're not the only ones who do this. Medicare does this when they have ACOs, and payers do this. For PPO patients, who is your PCP? You don't designate someone, but you can kind of tell by watching who do they go for their basic checkup visits. And so we use those, they're called evaluation and management claims. And we assigned whoever you had the most of those with, that's your PCP. So it's an attribution model, and we use the same kind of methods that Medicare and everybody else does. And there were some patients that we then took to a second level that we couldn't assign that way, but maybe had a prescription drugs all being prescribed by a certain PCP. That's right. So we got a few more patients that way. And ultimately, through that process, you can see 46 and 32, about 78% of all members in the APCD we were able to assign to a PCP. That's a pretty good representation. The final step was connecting those PCPs to their larger provider organizations. This is where we use the power of the RPO. So about 80% of those PCPs were in one of these 14 largest provider organizations. And some of the results we will report for everybody else, all the other organizations that just is a mix of the smaller groups that we don't have identified. But most of them fit into one of these larger groups, which is nice to see. And for some of the analyses, we then further group these into the larger types, and I'll explain why we do that in a minute. But we're grouping, you can see academic medical center anchored systems on the top there, and those are the usual suspects that we all know. We have a teaching hospital anchored group, community hospital anchored group, and those groups that are not hospital owned but are led by physician groups such as Atrius Health. So we're going to show some results by these larger groupings to see if the outcomes differ. Okay, so Natasha's going to walk through, let me just walk through this slide first, through some of the other descriptive statistics of what we end up with. So one other note is that for our extract of the APCD, we are just tracking patients in the Blue Cross, Harvard Pilgrim, and Tufts, so the top 3 Massachusetts payers. That's about 61% of the commercial market. Through this process, we get about 2 million patients in our full final data set. These include adults and kids. Today we're going to just show the adult populations. They're more comparable. It's easier that way. And the final product mix of who we have, you can see about 2/3 are in an HMO. So that's a little more HMO heavy than the full market. That's sort of the result of the attribution process. But we have a fair representation from the PPOs and the EPOs, which don't require you to choose a PCP. Some of the dollars are not in here. We only have the claims payments. We don't have settlements that might come through shared savings in this data. And we adjust the results. This is important, so note these flags in a number of ways. Patient populations differ. You don't want to make an unfair comparison between organization A to B if their patients are much sicker, for example. So some of the outcomes, all the dollar outcomes are adjusted for risk. And you'll see an orange flag that's going to indicate that. Some results are not adjusted, and the utilization outcomes are further adjusted. We'll talk more about this later for a number of other factors, such as socioeconomic factors and age and gender and payer and things that also should matter for utilization. Based on the theory and what we know, for example, ED visits are affected by more than just patient risk, but socioeconomic factors.
David, I may have missed this.
Sure.
What about Medicare and Medicaid? Are they in here?
I was going to get to that at the end, but we have actually run the Mass Health MCO patients through the same process. I'm not showing them today, but we have that data. Medicare is at a farther behind stage, but we're working on that
The reason
too.
why it comes up now is because I looked at the 66% HMO and I go, that doesn't look like the healthcare system of Massachusetts if you include Medicare and Medicaid. So this is just the commercial.
This is just the commercial. Although the Medicaid is, the NCOs, they are very highly in it. Yeah, not Medicare. That's right.
David, how did you come up with this fact?
Actually, those are derived in the data using patient diagnoses and other factors from the contractor or mathematical policy research who processes this data for us. So they're running the same kinds of algorithms that payers tend to use. It's based on things like age and health status for the most part. Good. Okay.
So as you can see here, APC members are concentrated among a relatively small number of provider organizations. About 83% of attributed commercial patients and 78% of Mass Health patients had a PCP affiliated with one of the 14 provider organizations. We identified the 14 provider organizations displayed here using a 10,000 patient minimum threshold to ensure reliable results. In this presentation, we'll be focusing on the commercial population, or the data in blue. But this slide illustrates that there's not only a high degree of variation among the provider organizations in terms of size, but also that these organizations have different mixes of commercial and Mass Health patients. As David mentioned earlier, for the first set of analyses, we'll be showing provider organizations grouped into 3 broad categories: the physician-led, the other hospital-anchored, which is community and teaching hospitals, and AMC-anchored. And as you can see here, in our sample, the majority of patients had a PCP that was affiliated with an AMC-anchored system. The final set of analyses we'll be presenting today are at the individual provider organization level. This slide illustrates some of the differences in patient populations among these organizations. For example, BMC has the healthiest commercial population among these organizations. Now this may come as a surprise, but as a reminder, while BMC has a high concentration of mass health patients, here we're just showing data on the commercial population. This low risk score is mainly because their commercial patients are younger on average. Meanwhile, you can see that South Coast has the highest risk patients, about 20% higher risk than BMC. South Coast commercial population are also from the lowest income zip codes on average, while Partners patients are from the highest income zip codes. We adjust for these differences in some of the analyses we're about to show. In some analyses, we also adjusted for the patient's area deprivation index. This is a geographic-based measure and is based on a number of socioeconomic metrics, including community income, but also things such as the percent of the population over 25 with a high school diploma and the percent of the population over 16 that works in a white-collar job, among other factors. A higher index value represents a higher level of deprivation, which has been associated with an increased risk of adverse health and health outcomes. I'll note that these are just a few groups and dimensions that we have, and as David had mentioned earlier, we'll eventually publish the full data on all the organizations using some of those visualization techniques such as Tableau. And now I'm going to turn it back to David to walk you through some of our results.
Okay. So the first step is going to be looking at variation by these broader organizational types. And why are we doing that? We do have a growing body of research that we are aware of that suggests that these structures do actually matter. And they tend to find results that are in the same sort of direction, that the hospital-owned practices tend to have higher spending and higher prices, and not big differences in quality. And you might imagine that that could arise through a number of mechanisms. It could be pressure to refer patients in system. It could be substitution of hospital-based visits, whereas a different organization would have that visit in an office without a facility fee. A number of reasons such as that. One study found from 2017 looked at different practices based on ownership status and looked at their Medicare patients and found 35% higher outpatient spending for the practices that were hospital owned, for example. Slightly lower physician spending, but more ED visits and more total spending. Other analyses, when looking at the Medicare ACOs, you can divide them into, is this ACO physician-led or hospital-led? And the physician-led ones have been more successful at earning shared savings and lowering costs below their targets, for example. And more studies have looked more at prices and found kind of similar sorts of results. And I'll note that most of these studies have had to use Medicare data. They've only been able to look at the detailed claims data that Medicare puts out. And really there's no examples that I know of anyone being able to have the power of the APCD and the RPO to do this for the commercial populations thus far. So we're very lucky and excited to be able to show some of these results today.
Then you get into the unique characteristics of Medicare payments as opposed to the commercial, so a little purpose. But maybe it's the right one to balance, assuming that the same thing plays out.
Yeah, it'll be really interesting to see if the patterns are the same in Medicare. I agree. Okay, so starting out, here's one result showing that by these types of organizations, you do have a higher share of APM use in the physician-led organizations. These differences are based on a smaller set of provider groups. This is actually from GIA data, but we were able to group them in the same way. So this might be one factor playing into some of the results that we're about to see. So here's a top-line result of the total spending broken down by these organizational types. You see a pretty big difference. It's about 17% top to bottom, comparing the AMC anchored systems to the physician-led systems. This is risk adjusted, and this is a difference in spending per year, per patient per year, so it's about a $1,000 difference. And other hospital anchored systems are in between. And this is the pattern we'll see in almost all of the spending data. And when we look deeper at the subcategories of spending to see where are these differences coming, the vast majority comes from the hospital outpatient area. On the right, you see a 72% difference in hospital outpatient spending between the AMC anchored groups and the physician-led groups. That's about $800 of the $1,000 difference that we see.
David, how would you define outpatient spending? Is that like MRIs and things of that nature? Is something specifically that really drove that?
It's a setting of care definition. It's based on the setting. Where did that occur in a hospital outpatient department? So it's not specifically service based because you could have an MRI in a freestanding or an office facility. So, but yes, a lot of labs and tests are in there, and we'll even break down to labs specifically in the next slide.
But do you know how much of this is higher total utilization versus a change in somewhere where the services are taking place?
We haven't been able to break that down exactly, and there are price differences and utilization differences going on here, so that is definitely a.
Because some of this will just be the facility fees associated with doing something in the AMC on the building, which is a very real issue.
Yes.
And some of it may be increased use of those services because they're readily on hand, reimbursed well, and all of that.
That's right. That's a good way to break it down.
How do you deal with, so you may have an MRI unit or a testing unit in an academic center, which is used both by strictly outpatient patients and also inpatient patients. But it's in the same place. What is that? Do you count that as an inpatient?
Right. It sort of depends on how the claims are, whether it's part of the DRG or whether it's a separate.
Well, DRG would be easy for Medicare. Yeah. For commercial, I'm asking because I don't know the answer to that, but a lot of these big academic medical centers use the same facility for both people who are essentially ambulatory and come into the outpatient department and for the people who are in the inpatient department. I just don't know.
That is true, and those are going to be, for the most part, appropriately in either of those two categories, depending. It's not always going to be parsed out perfectly, but usually it's going to get binned separately, depending on whether it's part of an inpatient episode or an outpatient.
So if it's an inpatient episode,
we can bin it.
wouldn't capture it in the outpatient, even though it's done in the same.
That's right. It should not be.
Okay.
So you can see that there are differences in the inpatient spending area, about 16% top to bottom. And this slide sort of gets at the substitution that David was mentioning, that if you then look at the physician and professional spending, it is higher in the physician-led groups. And there is probably some amount of substitution between those categories. But you can see that the degree of difference here is not nearly as much as in the hospital outpatient difference. So there's probably some offset, but not full offset.
That's without testing.
This will be, if there's an MRI and there's a physician fee billed as part of it, this is the physician fee part. Okay. Other subcategories of spending, lab and pharmacy, follow the same pattern. Okay, now before showing some of the utilization outcomes that we have so far, I'm going to show some of the factors we adjust for and how much they matter. These are the factors that are in that adjustment for ED use. And as we mentioned earlier, the risk score has a big effect. What this table is showing is that for someone in the highest level of risk, which is the sickest 3.3% of the sample, compared to the 60% healthiest segment of the population, 4.5 times higher ED use. Okay, that's not surprising. That's what the risk score should predict. Then some of these other factors are a little more interesting. So when you look at the income of the person's zip code, somebody from a 93,000 average income zip code at the 75th percentile is about 9% less, fewer ED visits than someone from a 25th percentile zip code. When we look at that area deprivation index, the differences are smaller, but it's still significant in the adjustment. Someone from Somerville, which is a relatively high area deprivation, 3% more ED visits than someone from Arlington, which is on the lower end of that scale. Males have more ED visits. Fully insured people have fewer ED visits. And the age group looks maybe counterintuitive, but someone 55 to 64 has fewer ED visits once you control for the risk. So all of these factors are everything else controlled for. Yeah. So if you have a healthy 60-year-old, they're going to have much less ED use than a typical 25-year-old, which we actually see in the data. Okay. So all these factors are at play in slides like this. So now we're showing total ED visits in the blue and avoidable ED visits in the yellow across these same provider groups, and you see a 29% difference top to bottom between the AMC groups and the physician-led groups in total ED visits, and a 30% difference in the avoidable ED visits. We also looked at non-recommended imaging, which is borrowing some measures we developed in last year's report. We combined imaging across a number of measures such as lower back pain and plantar fasciitis and things that are not recommended, and grouped them together to form a rate across these types of organizations. We see not as much variation here, but the physician-led groups were lower in terms of these non-recommended or sometimes called low-value care measures. Okay, so that's that set of results, and now we're going to show a few here by individual organization, same kinds of results. Here's the total spending result. Yeah.
Do we have to, can we match these up to any patient assessments about their ability to access care? Systems?
There are HEDIS measures, for example, of a number of access type measures that are often reported at a lower unit than these. They tend to be reported at kind of maybe the Harvard Vanguard level with NH-rates, for example, but we could. I mean, all of this work, we could break it down to the lower levels and try to marry those up.
Aggregating those up to these same levels, so we can
Yes.
see something like when you
That's a great
see
idea.
more avoidable ED visits.
Yeah.
What are patients saying about their ability to access primary care?
We would like to do that.
Consistent with
Yeah. Part of the problem is if we're using those HEDIS measures reported by other organizations, we don't always know how to aggregate them up. They don't tell us how big they are, but
yeah.
if we can generate those ourselves, I think we can get part of the way there.
So David, the first time I'm seeing these numbers.
Yeah.
And they generate, in my mind, 20 questions per slide.
Yeah.
And I'd be very nervous, and I hope you're not planning on issuing these slides in that cost report without knowing a lot more. For example, this issue about ED business, and much higher than the AMC. I mean, I got a ton of questions. Who generated this? Was it the AMC, or was it the connotation? Did we really do it? Is this a? And you may have a lot of answers, but I'm very nervous about seeing a lot of these statistics in that report without knowing
Okay. So what sort of?
I don't want to be on the other end of the blast.
Okay.
I
We
mean,
have shared
I
these
love them. I mean,
yeah.
these are great, but I think we need to anticipate questions coming in. AMC, ED, I mean, the AMC, well, yeah, I didn't ask you to go to the ED. Why'd they go to the ED? Who are these patients? Did you really adjust for them? If you lie purposely in the academic medical center, say, come to my ED and be wasteful, you get the point. I mean, I'd like, it's an interesting set of numbers, don't get me wrong. But I don't know, but about the others, boy, I think we need to spend a lot more time.
We have talked to, yeah, okay. I'd love to talk to you, Marcus. We have talked to some of the organizations about these numbers.
That we have
They're not
good insights, that's great.
I think we do. And part of what you're saying is why we do want to look at the avoidable ED visits, and not just the total ED visits.
Yeah, but how do you define it?
There are different ways to define them. Yeah. Yeah.
Who's avoidable to who? Who caused the abortion? Is it the delivery systems or the patient?
A mix of things.
David, I'm sure you have a whole bunch of questions.
I do.
Among the other, everybody was out.
Okay. Well, let me show some of the individual organization results, and then David can ask any further questions. So in terms of total spending, here are the patterns by these 14 organizations, and they are color coded here to indicate their category as we were showing in the previous set of results. And you see that the orange groups are all at the right end with the lowest amount of spending. And partners is the highest. This mirrors the same data we see in the TME. But note here that now we have the PPO patients in addition to the HMO patients that are in that TME data. And when you look at acute inpatient spending, similar patterns to what we've seen before. The total variation from top to bottom, I think, is about on the order of a third here. There's much more variation in outpatient spending, as we've seen. This is more than about 2 to 1 from top to bottom in the hospital outpatient spending on the top. And then in the professional spending category on the bottom, its variation is smaller. And it's again meeting those similar patterns with the outpatient spending. You see much lower amounts in the physician-led groups on the top.
Again, just if there is a difference of HMO, non-HMO, based, I mean, again, you just look at this and say, well, gee, if we only had more patients in the physician-led, we might be able to do better. But if it has to do more with the payment structure than the physician-led, I don't know. Or does it have to do with are all these adjusted by the complexity of the patients?
Yes.
You see, you may know all the answers.
Sure. I see what you're getting at. I mean, the ED visits are adjusted by the full set of things that we showed before. For the non-recommended, researchers tend to not adjust those, making the argument that these are services that really shouldn't be performed regardless of the risk of the patient. And they don't tend to find a big difference when they adjust for those things. So it depends on the nature of the data as to what it's appropriate to adjust for. But as for the reasons underneath these differences, that's what we really do want to think about and
yeah,
talk
again,
about.
we can throw them out as areas for further research. I mean, I just, again, I find A, they're very interesting, and B, but one thing we don't want to do is attribute fault or responsibility for things that we really don't know why they're happening. I just think we need to think of the methods as reasonably fair as we can and understand this. And as I said,
It's a great point, Cheryl, and I think we're very careful in not assigning causality to some of these different statistics. And certainly in the case of physician-led organizations, as we said before, they have a higher percentage of payment coming to them in the form of alternative payment methodologies, much more so than the AMC-led. So how much of maybe part of this is the payment structure?
That's what I'm thinking about. I mean, but the point is, David, once you put them out, you may not, but the implication sits out there. And I just think we need to be prepared to answer questions. As I said, I'm particularly an ED visit on his face. I don't know how to explain. It's troubling in terms of what's behind it. The same thing with the imaging. Is it that the physicians in those organizations are less willing to image? Partly because maybe they don't get paid for the imaging, partly because they're who knows, or is it because of the payment structure that they're under? You know, so we know a lot of these physicians take an atrius which may have a higher concentration of HMO patients than people that are in some academic medical center. So they're in a situation where they're in regrets versus the others that are generating the money. Well, okay, so is it the physician-led that's generating this, or are we concerned about the payment structure? That's some of the questions that are here.
Yeah. And those things can go together.
Yeah, they might, and that's all fine. I mean, as you said, they're great, and they're new, and no one's ever done it this way, and it's wonderful. But as I said, the extent of we either qualify them and so that we questions. Yeah, so I just think we need, I'm not saying we shouldn't do it, I'm just saying we need to be careful. I think those of us who are more interested in just need to have that discussion.
One way to think about this is that we might want to use these to develop a research plan for the next 6 months or so. Maybe we could do a little deep dive into some of these, particularly some of these things, particularly that third one application like let's avoid all emissions to emergency hardware. That maybe we could take some of those and try to look in more and say, okay, here's what they are.
I think that's absolutely right, and Chair Altman, hear your caution. I think in some cases where we see big variability among provider organizations in how, the same, adjusted for the health of that patient, adjusted for the rest of that patient, huge differences in where spending is occurring and where utilization is occurring, that raises a whole bunch of questions. And in some cases, it may be that our risk adjustments aren't properly taking into account all of the different things that may drive utilization. That's certainly something that we've heard from organizations. But at the very least, it can elicit a conversation to say, just as we saw with the rates of non-recommended imaging that we put out last year, we went and talked to the organizations that were really on the low end and have been performing really well. We asked them, what are you doing? And they said, oh, well, we've incorporated into our EHR that there's a flag immediately before any time an MRI is ordered, and we have clinical champions. And so there may be a lot of different reasons why organizations differ in these performances. And I think it's very careful for us to not assign blame or praise necessarily at this point, but it does certainly provide a context for further conversations to say what might be driving really good performance in some areas and some performance that is high in other areas. And that's really probably the next whole year of work.
Thank you. I agree. And on the ED front, for example, we talked to one of the groups with relatively high visits, and they said, that they weren't so surprised. That's 2014. They said we've been working on alternative sites of care, having it more accessible for people to have after-hours visits for their physicians. And that's one of the factors that we look at. Okay.
David, I might have a little over time.
Yes, this is really the same sorts of results we've seen before, so I don't need to show them. So here are some of the plans that we have for the future. Additional outcomes that are in the works right now, for example, looking at hospital visits and avoidable hospital visits, readmission rates, post-acute care use, end of life care, variations in are people sending community appropriate care to community hospitals. We have all of this data at hand and we're just working it up right now. In terms of other payers and years, we have the 2015 data on hand and we're in the process of working that up as well. Medicare data is on its way, and the MassHealth MCO data we have analyzed, so we just didn't show it here today. And there's a number of other things that we could do with this in addition to this variation sort of work. We're using the structure to look at, to help evaluate how the PCMH Prime program is working and look at different organizational outcomes there. We can use this for some of the market share types analyses that MP tends to think about behavioral health integration, comparison of organizations at smaller units other than these bigger organization levels, and much more that I couldn't fit on the slide. So that's sort of where we're going. Pretty amazing.
Excellent. I know we're over time, and usually we have comments from the audience, but maybe we'll forego those for this particular meeting, just in the interest of trying to give people a little bit back of their schedule. So if there's nothing else, then we will adjourn until our next meeting.
Nope, great meeting. Thank you, commissioners, for being here today. And this would highlight our board meeting next Tuesday. Usually we have board meetings on Wednesday. It is on Tuesday at 12 o'clock. We have a full agenda. We're going to be showing more results from the cost trends report. We're going to have more results from the chart program. So look forward to everyone attending next week.
Okay, we stand adjourned. Thank you.